Okay, Richard,
Good.
you're up.
Thank you. Good morning, everybody. Thanks for coming. I was hoping to show photos of the wallabies holding up the Webb Ellis Cup. Unfortunately, it was not to be.
The All Blacks one.
The All Blacks won, thank you. Yeah, thanks for reminding me. But in terms of priorities, when you have to get up and speak in front of your colleagues, it's just good to be wearing pants sometimes. So, the objectives for today: explore best practice diagnostic techniques and how we can improve the diagnosis of non-muscle invasive bladder cancer, define the patients who are most at risk of recurrence and progression, optimizing our intravesical therapies to prevent recurrence and progression, and looking at BCG refractory disease and what's on the horizon with clinical trials. So non-muscle invasive bladder cancer, as you all know, there's a large burden of disease. 70% of all new bladder cancer diagnoses are non-muscle invasive. And these are the Canadian cancer statistics for 2015, the predicted numbers. And you can see it's 4th on the list in men and 12th on the list in women. So our initial evaluation for this disease hasn't changed much over the last 10 to 15 years. You do a hematuria workup, a flexible cystoscopy in the office, and then a TURBT. And disappointingly, the recurrence of the disease still remains high, 50% with TA low grade, all the way up to 50 to 90% for carcinoma in situ. And progression of this disease can be a life-threatening event, and this is why it's so important. High-risk non-muscle invasive bladder cancer carries a high probability of progression to muscle-invasive disease at a rate of about 25 to 50% over 5 years. And this pie chart just shows what the long-term outcomes of patients with high-risk non-muscle invasive disease are. Roughly a third alive with no disease, a third dead of the disease, and a third died of other causes. Carcinoma in situ is of particular concern. Without treatment, 54% will progress to muscle-invasive disease. With BCG treatment, approximately 10 to 20% of even complete responders initially will eventually progress, compared to 66% of non-responders initially. So, making the diagnosis. What's new in the guidelines from the EAU in 2015? Avoid cauterization as much as possible during your resection. And this is an important point. We often use cautery to take out these lesions, leaving the pathologist with a difficult job. Venkatramani's group looked at bipolar versus monopolar as a modality. Bipolar, they found, this is an RCT, single center, 147 patients. They found that the diathermy artifact was reduced with the bipolar resection, but there was no difference in the rate of obturator kick, which I thought was interesting, bleeding, operative time, or the hyponatremic outcomes. And this slide shows what the pathologist looks at. Dr. Jones not here this morning. And you can see with severe cautery artifact, it's very destructive for the architecture of the lesion. It makes it difficult to make a diagnosis. I think perhaps we should be using the cold cup biopsy forceps a bit more than we do to take a chunk of, particularly of the base, after resecting the lesion. Do people in the room feel strongly about cold cup biopsy forceps? Yeah, I know we use them a lot in Australia.
Or get enough to stay filled. You get it great.
Mm-hmm. Martin, shaking your head.
I think that's the only period before I have to CIS is bad, but you get a tumor, you just reset because the cold cup isn't going to get the muscle or margins of invasion if that's interesting. Cold cup will help protect against grade, but you add muscle with that, plus cold cup.
Yeah, certainly.
Other prognostic indicators for cardiovascular agents that are difficult to see small sample.
I mean, obviously you resect the whole lesion with the loop, but then you want to take additive samples with the cold cup to try and give best possibility of diagnosis.
The volume of tumor.
Yeah, true. So there's pros and cons to that. Do it perfectly. So in patients with positive cytology but negative cystoscopy, We need to exclude upper tract disease. We need to exclude CIS in the bladder using random biopsies. And maybe they should be not so random, but systematic, and I'll show you that. And also to sample the prostatic urethra to look for tumor. So when to sample the prostatic urethra? In positive cytology, negative cystoscopy, and in the setting of high-risk disease. So why is that? It's a very important predictor of muscle-invasive disease, and Huguet in European Urology showed that it was the only predictor of muscle-invasive disease in those who failed BCG going on to cystectomy. So if you've got a high-grade lesion in the bladder and you've got disease in the prostate, that's a predictor that you're going to have T2 disease. And they recommend that you resect between 5 and 7 o'clock from the bladder neck to the viru, taking 2 decent swipes. So random biopsies, they should really be taken systematically from around the bladder in these locations shown. The importance of second or TUR cannot be overemphasized, and this should be done within 2 to 6 weeks of initial resection, and it's based on some very good evidence. So Sfakianos in 2014 showed in 1,000 patients that had BCG for their non-muscle invasive disease, the recurrence rates with a single turbot were 43% compared to 9.6% in those who had a repeat. And they recommend within 6 weeks for all high-risk patients, so those who have high-grade TA or any T1. Furthermore, the progression-free survival was different between those two groups. No second turbot versus repeat, and also shown in Divrik's analysis in European Urology. Experience at TURBT is very important, and so for young surgeons, it's an important job to get right, essentially. The odds of you leaving behind residual tumour is 7.5 over your experienced colleagues, and not getting muscle in the specimen on an odds ratio of 8.5.
It's interesting that we discussed this at the Royal College, and the chief examiner was saying the residents as a group always delegate TUR bladder tumor to a very junior resident, but to do it well, you actually have to be more experienced. Just like her.
That's right.
Like you delegated to, and then the chief residents are going to get a nice wake-up call when they go in at practice, and they do channel turns, and they're not really resecting as aggressively as they need to in order to reduce the chance of that patient having complications of unresected adenoma.
Yeah.
So this is an underappreciated operation.
We've all been there, some more recently than others. Yeah. Yeah, no, that's a good point. I think it is left, it's seen as a simple procedure that juniors should learn early, and then it's not often done that well. So the importance of muscle in the specimen, this is a review of the Los Angeles area SEER database with 1,865 patients. And you can see that when muscle was not mentioned, the disease-free survival, the bladder cancer mortality is far higher than if muscle is absent or muscle is present in the specimen. So it's essential that muscle is taken, that muscle is mentioned in the report and the pathology report. So this systematic review from Richards et al. Summarized their summary findings on the principles of management are complete resection with muscle, repeat turbot, examine the patient under anesthesia for aggressive lesions, and this is something that's often forgotten also in the OR. Do a bimanual exam, do a rectal, and the importance of post-op single-dose intravesical chemotherapy. I'll talk more about that later. So most of you would have seen this sort of thing. The picture hasn't come out particularly well, but essentially this is photodynamic diagnostic cystoscopy or fluorescent cystoscopy that uses hexaminolevulinate compound that's instilled into the bladder before the procedure. It's known as CysView or HexFix. It's a protoporphyrin 9 ring that binds to neoplastic tissue preferentially, and then it can be visualized with a blue light spectrum illumination between 380 and 440 nanometers. And what this slide is supposed to show is that you've got subtle areas of CIS on the left at white light, and then on the blue light you can then see the red areas around that ureteric orifice. And not only is it a great whiz-bang tool, but it's shown to reduce recurrence at significant rates. In this study in 1,345 patients, they showed that significantly more tumours were detected in both the TA group and the CIS group. In 26% of all cases studied, the CIS was detected only by fluorescent cystoscopy, and the recurrences were significantly lower with fluorescent cystoscopy. We looked at it a couple of times in Australia as a trial, and it was deemed too expensive for the hospital. But Garfield et al. In the Canadian Journal of Urology showed a cost analysis showing that it can be effective because you save $5,000 in costs for recurrences over 5 years, and so it's a worthy investment. Anybody used it?
I haven't, but what's the comparison between using the photodynamic approach versus multiple random blood like you advocated earlier, 6 or 8 or 10 biopsies? What's the comparison?
Well, I guess if you think about you know, the nature of CIS, whether it's, you know, the chance of missing it is reasonably high even if you do random biopsies, whereas if you can localize it with this sort of technology, your hit rate's much higher. I haven't seen any data comparing those two.
It's not approved in Canada yet, but it's coming.
Right. So what we do have at the moment, we have this in the office, is narrowband imaging. This is Olympus technology. It works on the digital cystoscope. It's very nice. It filters white light and allows a wavelength of penetration that is absorbed by hemoglobin. So it highlights the blood vessels in the bladder wall. But it's not cancer specific. So you end up seeing lots of inflammatory spots and things in the bladder that illuminate with these brown blood vessels or the bluish blood vessel color, but they're not necessarily cancer. So maybe a higher false positive rate if you were to biopsy based on that. Narrowband imaging, though, has been shown to improve recurrence again, recurrence-free survival in this study from Harry Herr. This was a randomized controlled trial comparing the two modalities for a second look TURBT. He had 127 patients in each arm, and he looked at recurrence-free survival at 2 years. This study was criticized, though, because there was no post-op installation of chemotherapy, and the patients had BCG but not maintenance, and this possibly affects you know, the outcomes of the patients in general, and therefore whether there's a demonstrable difference. So in terms of what you want from the pathology report, and I see Dr. Jones has joined us. Hi, good morning. There's such importance in consistency of the reports and using standard terminology. The EAU guidelines recommend still reporting the grade 1, 2, and 3 of the cancer, as well as whether it's low grade or high grade. And that's because in prognostic models, one hasn't been shown to be better than the other in predicting outcomes. So they recommend using both still, and mention of muscle, as we said. So if we look at the bottom of this slide, you can see that most of the old grade 1s are now pun lumps. Grade 2s are largely low grade, although some of them are high, and all grade 3s are high grade. In terms of urinary markers, there's been a lot of study in this area, but not a lot of headway in terms of replacing cytology and cystoscopy. A lot of this was born out of the fact that cytology is not particularly sensitive at picking up cancer, except if you've got very high grade, particularly CIS. But it is very specific, so most of these tests improve the sensitivity but give away some specificity in detecting bladder cancer. And it can be influenced by benign conditions and BCG, post-BCG treatment, etc. So who is the patient most at risk of recurrence and progression? So from the EAU, they defined low risk, intermediate risk, and high risk, which is at odds with the AUA. They don't have an intermediate risk group. Essentially, the intermediate risk group are those with grade 2, because most of the lesions we see are low grade TA in the low risk group, primary solitary, And the high risk are, of course, the high grades, the CISs and the T1s. And then the EAU has included this category, multiple and recurrent large low-grade tumours. Greater than 3 centimetres is a pretty large bladder cancer, but they've included that as a high-risk group. That led to this communication to Bladder Cancer Journal from this group of very renowned bladder cancer investigators and surgeons, saying that they thought that this new group in the European classification actually has about half the risk of progression as the other criteria in that group, and so should remain in an intermediate risk category. AUA shows a low risk, and then low risk with concerning features are the multifocal large volume low grades, the high risk as stated, and the concerning features on high risk are those that recur after initial therapy. But we can do a little bit better than that, and I'll talk about that in a minute. What are the other high risk features? These are the EORTC risk tables. I think these are very nice. They show all the factors that you find at cystoscopy and how it accumulates risk scores. You can see you get very high scores for concurrent CIS and also for T1 in terms of progression risk. And then when you calculate your score, you can look at the recurrence and progression charts and calculate what the patient's risk is. The Cueto risk calculator, which is developed by the Spanish group, is for the BCG treated population, so this is also useful in predicting who's going to fail BCG. It is in Spanish, but you don't have to be a genius to work out what recurrencia and progresión are. So, what are the important other high-risk factors for high-grade disease and TURBT? So, at repeat TURBT, any residual disease puts you at increased risk. So, if you had T0 at repeat TURBT, you had excellent prognosis. If you find TA or CIS again, that decreases your chance of cure. And then T1 is the worst, obviously. As Dr. So mentioned, if you have lymphovascular invasion in the specimen, this is an important prognosticator, and there's a significantly lower disease-specific survival if this is present in your TURBT specimen. Some of the high-risk features on TURBT from Andius et al. 121 patients. These patients all had T1 disease. Again, vascular invasion and solid tumor versus papillary were hallmarks of poor prognosis. Dr. Black published in Urological Oncology on variant histology and showed that these particular variants obviously confer a poor prognosis, regardless of stage. Micropapillary, as we know, in this study in T1, does not respond well to BCG, so upfront cystectomy should be considered. And even when you, when you do upfront cystectomy, patients do well. If they get primary BCG, they do poorly. NCCN guidelines consistently showing cystectomy as an early treatment choice in T1 disease high grade and residual disease even after T1 low grade. And this is an important message to remember. Patients do die of non-muscle invasive bladder cancer because it progresses without us knowing. So the guidelines in the EAU and AUA both include radical cystectomy as well in their recommendations, particularly for high risk with recurrent disease. And a lot of this comes from the work of Herr, initially delayed versus early cystectomy. He included both the non-invasive and the invasive progressors in this study, and you can see that early cystectomy improved disease-free survival. Why? Because there's a problem of understaging at all levels. Late failures confer a poor prognosis, and there's excellent survival rates when you do a cystectomy for T1 or CIS. So one other point of difference, intermediate risk tumours, it suggested that we should actually be giving these chemotherapy for longer than the single post-operative dose, for up to around a year. This could be BCG, but it can also be mitomycin C, epirubicin. And those ones are really the in-between categories. They're not the low grades, they're not the high grades, but they should be getting more than the low grades, which are just a single post-op dose and then surveillance. High-risk tumours, again, should be getting BCG installations for 1 to 3 years, as we know, and radical cystectomy for those who refuse. They need to have intravesical full-dose BCG. So how do we optimize our intravesical therapies? So the single postoperative dose, there have been 3 large meta-analyses with over 7,000 total patients showing that there's a reduction in recurrence over TURBT alone. Mitomycin C, epirubicin, and doxorubicin have all shown benefit, but no differences between these agents. So which subgroup benefits the most has not been proven, but there's some low level evidence that it's the low risk ones that benefit the most. So BCG refractory disease. This is high grade and non-muscle invasive that represents at 3 months after induction. Further treatment with BCG is associated with an increased risk of progression, so they're suggesting that these are not the patients to persist with BCG. CIS present at 3 and 6 months. An additional BCG can achieve a complete response, but they need to be monitored closely. So for those who are BCG refractory or fail BCG, many different things have been tried. This is one avenue where you reduce the dose to 1/3 and add interferon. But you can see that if you've had more than 1 prior BCG course, you don't do well. And if you're refractory early, you don't do well either. So how can we improve BCG delivery? Because if you've ever worked in the BCG clinic, you'll know that patients get a lot of symptoms, they get a lot of suggestions of urinary tract infections that stop them getting their weekly doses. So this evidence shows us that simply the presence of leukocyturia and microscopic hematuria is not a contraindication for BCG, and that you should persist with the treatment. And of course, white cells in the urine is an inflammatory response, and that's essentially what we're doing with BCG. So in Australia, we were using the Connaught BCG strain until it ran out in 2012, and then we switched to the Tice. There's no evidence that one is better than the other, although anecdotally, growing up through training, I was led to believe that the Connaught was a more virulent strain. Now the Connaught is still not in supply. The Tice is in supply, as you know, and there are trials, which I'll talk about later, looking at strain difference and outcomes in a prospective fashion. So what about 1 year of maintenance versus 3 years? The whole issue there is that patients don't survive, well, they don't persist to the end of the 3-year maintenance because of how rigorous and draining it is getting BCG courses every 6 months. It's painful, it's full of complications, and people hate it basically. So in this randomized control trial of 1,300 patients, they showed that when it's given at full dose, 3 years maintenance reduces recurrence compared to 1 year in high risk but not intermediate risk patients. So if your patients are high risk, they need the full 3 years. If they're not, they can get away with a year. So why does BCG fail? Can be host immune incompetence, can be inadequate resection initially before BCG was commenced. The tumor can be resistant. The treatment schedule is inadequate, or they're given too few colony forming units, or they're not getting enough contact or dwell time. We tell them to keep the BCG in their bladders for 2 hours. It's not always possible when you get urgency from the inflammation to do that. And excess BCG can induce immunosuppression, which is counterproductive, obviously. After BCG failure, we have the chemotherapy and the immunotherapy arms. And the mycobacteria complex with nucleic acids is an interesting one that I'll talk about. So historically, many different avenues have been tried for those who fail BCG, but all of them fail to exceed the 20% mark for 2 years, no evidence of disease. And really, radical cystectomy is the only one that consistently gives good long-term and high rates of cure. Valrubicin looked very encouraging early, and that was FDA approved for those who'd failed BCG who are unfit or unwilling to undergo cystectomy. But long-term, the cure rates dropped to 8% after 30 months. So perhaps we can better predict who's going to fail BCG and then change avenues in terms of intravesical therapy early, or consider radical cystectomy early. So cytokines and their response to BCG can differentiate those who are going to respond from those who aren't. Their levels directly correspond with the risk of recurrence and the time to recurrence. So this paper from Ashish Kamat looks at a cytokine panel to produce a nomogram, and essentially it's looking at changes in IL-2, IL-6 and IL-8 in the urine 4 hours after the BCG injection. And that has an area under the curve of 0.85 in predicting who's going to respond and who's not going to respond. So this work from Nunez Noteris looks at the fact that BCG is a T1 cell polarizing immunotherapy. It correlates with the pre-treatment tumor microenvironment, and they postulated that if you resect the tumor and submit it to immunohistochemistry, when you find a high T1 preponderance in the tumor, that means that the BCG is not going to assist you in the T1 response, right? So those tumors that had a predominance of T2 cells over T1 are more likely to respond to BCG because of its T1 inducing properties. And again, high predictive value, AUC of 0.94. So what about mitomycin C? We've increased the dose and reduced the volume to increase the concentration of the drug. We get patients to fast and limit their water intake in the morning so that they are not making much urine, they're dry. We also get them to take a small sodium bicarbonate load orally to help alkalinize the urine. Those have all been shown to improve the efficacy of the drug. 60-minute dwell time has been postulated over 30 minutes, but there's not good level evidence to support that. And now hypothermia and EMDA are on the way up, and we'll talk about those. So hypothermia, this is the Synergo machine. Basically, it has a catheter system that has sensors in the bladder, these thermocouples, which measure the temperature of the bladder wall. And the central applicator radiates heat to heat the urine and heat the drug and heat the bladder. They also cool the catheter to prevent urethral heating and also to prevent breakdown of the drug if it's exposed to too much high heat. This has got some evidence behind it, 160 patients, 80% were BCG failures. They looked at MMC induction and maintenance in the usual protocol, and a follow-up of 75 months. They showed that their recurrence-free survival was 60% at 1 year and 47% at 2 years, so well above that 20% mark that we were seeing in the historical BCG failure group. And the progression to muscle-invasive bladder cancer, I think, was quite impressively low at 4.3%. This is the machine that we use in the clinic for EMDA. It's called the Physionizer. It basically has an electrode connected to the catheter, and it has these two yellow pads that sit on the suprapubic skin with jelly underneath them, and that allows the electrical current to transmit. It's a 20 milliampere current, and the patients have the MMC in their bladder for 30 minutes with that the current running. This is based on evidence from Stasi that showed that BCG sequenced with mitomycin using EMDA is superior to BCG alone, and we're doing that for some patients as well, sequencing 3 sets of BCG with 3 sets of mitomycin EMDA treatments, doing both induction and then maintenance. So induction is actually 9 weeks long, so it's quite a slog for them. And then this study also from Stasi showed that if you give mitomycin C and EMDA before doing a TURBT, you greatly improve your recurrence-free survival. And the theory of that is that you're preventing implantation of cells at the time of TURBT. So you go and do a resection, you liberate lots of cancer cells, they implant in the bladder wall when you leave. But if you give chemotherapy before, those the environment is set up for prevention of implantation. So clinical trials, there's a multitude, and this is all born out of BCG failure, essentially. Patients wanting to keep their bladders, what can we do for them to improve the chance that they're going to be recurrence-free with non-muscle invasive bladder cancer. There are adenoviral vectors that transform urothelial cells to produce interferon, and there are checkpoint inhibitors that are being used, tyrosine kinase inhibitors, mTORs, and delivery molecules that are complexed to active agents, chemotherapy agents, etc. So some of them build on the success of BCG. So for example, we'll talk about the bio-niche mycobacterial cell wall nucleic acid complex. There's trials looking at vaccinating patients with BCG before you give them the intravesical dose as an immune system primer. Recombinant BCG, the work of Van Rijn and Wrench, giving BCG the Listeria lysine property or protein from Listeria monocytogenes, which allows essentially breakdown of urothelial cells to get better access and better tissue penetration, and BCG and mitomycin, which we talked about. So MCNA is basically mycobacterial cell wall complex with an anti-neoplastic agent, a nucleic acid. It's immunomodulatory, just like BCG, and it also has a direct chemotherapeutic effect. The cell wall comes from a different mycobacterium species. It's the flea species, not the bovis. So this study from Morales looked at disease-free survival at 1 year, 129 patients, most with CIS, 107 were BCG refractory, and the median follow-up was 34 months. And this shows that they're getting pretty good disease-free survival rates. At 1 year, 35% disease-free survival for papillary, and don't forget that these are BCG failures and high risk, and about 20% at 2 years for all comers, including the CIS, and 32% at 2 years for just the papillary cases. And those that had a response had a pretty durable response for 32 months. These slides are from Peter Black. This is the PRIME trial looking at what is the randomized trial to evaluate the difference in BCG strain and whether or not giving a vaccine for T-cell priming improves BCG cure rates. And so as we discussed with the Connaught versus Tice, that was the initial plan for this trial, was to compare the two, but because of the unavailability of Connaught strain from Sanofi Pasteur, they're using a Tokyo BCG strain, comparing them head-to-head, and then also comparing those that get an inoculation with the Tokyo BCG vaccine before delivery. So patients register, they get a MAN2 test to look for previous TB exposure, then they're randomized to either BCG induction and maintenance with Tice, BCG induction and maintenance with Tokyo strain, or the vaccination followed by Tokyo strain. Eligibility, high-grade TA, T1, CIS. They have to be papillary tumor free after TURBT, no prior BCG therapy obviously, and MAN2 test negative. They're looking at non-inferiority essentially of Tokyo strain over TICE, and also they're powered to detect a 1.4 hazard ratio in the reduction for those that have priming with the vaccination. So what about immunotherapy? There's lots been said about checkpoint inhibitors lately in the metastatic setting or in the adjuvant setting for high-risk cancers. Essentially, PD-1 allows T cells to switch off inflammatory responses during infection to curb autoimmunity. You don't want your immune system to go rampant and destroy your body every time you get an infection. So PD-1 basically keeps the T cell response in check. The tumors obviously very clever. They use the PD ligand, PD-L1, to also switch off T cells. And so the theory is if you're doing a T cell immunotherapy like BCG, why not use a checkpoint inhibitor that will allow T cells to function more effectively. And there are a number of clinical trials. There's a phase 1 study, a safety trial of pembrolizumab in combination with BCG. There's a phase 2 trial of atezolizumab, formerly known as MPDL3280A, in the pre-cystectomy neoadjuvant space. And they're looking at what is the intratumoral T cell density like and what is the pathological T0 rate like in cystectomy specimen. This SWOG trial is a phase 2 trial looking at BCG unresponsive patients who then go on to cycles of atezolizumab according to the schedule shown, and they're looking at complete response rates of 6 months. This randomized prospective phase 2 study is looking at BCG given in combination with a PanVac vaccination, which essentially is a pox virus, a vector-based vaccine that's been shown to induce T-cell CD4 and CD8 response to tumor-associated antigens, to CEA and mucin-1, and it also contains transgenes for human T-cell co-regulation, so interesting one there. This is work from the UBC group and people in this room, a complexed hyperbranch polyglycerol with docetaxel. So this polymer, the idea this polymer delivers the docetaxel drug for better bioavailability of docetaxel to the urothelium and to the tumor. And they're looking to do the first in-man trial, phase 1, phase 2 with this drug soon. This is the Instaladrin, the adenovirus that has an interferon gene in it, and the gene is delivered into the urothelium, which then produces interferon. They've shown good rates of, good concentrations, of interferon in the urine following installation with this drug. It's currently in phase 2 trials, looking at recurrence-free survival with 4 cycles of this in the BCG refractory population. This one is a diphtheria toxin sequence, which is again delivered by a DNA plasmid. The H19 is the promoter switch, and the diphtheria toxin is the effector arm that kills off the cancer. This is in a phase 2b trial at the moment. All right, that's all I had for you. Any questions, comments?